I'm honored to chair this panel. We'll have a beautiful couple of presentations, and I hope you'll enjoy mid-October temperature here in Israel. It's pretty cool, like 35 degrees in Caesarea. But in the evening, it gets pretty cool, like 24 or 25. So we'll do our best to focus, although it's very cold. As I mentioned, we have two beautiful lectures today, this morning. One of Professor Robert Drake and the second one of Mike Slade. I had a discussion with them. They warned me not to present their rich and glorifying CVs. So I'll start with presenting Professor Robert Drake, who is professor of both psychiatry, I believe, and family medicine, and he published almost 400 articles and like 25 books, if I do remember, and this is a good test for my short-term memory. Welcome here on board. The second one will be of Mike Slade, that I will present him shortly later. And Professor Drake will focus on rehabilitation and recovery and evidence-based practice.
My task this morning is to try to give you an update on evidence-based practices in psychiatric rehabilitation. Just by way of background, I've been working in this area since 1980. I started the first assertive community treatment teams in Boston about that time, and worked there for several years, and then for the last 20 years or so have been trying to develop other evidence-based approaches to psychiatric rehabilitation. I'm required to give financial disclosures by the US government, and so here's a list of agencies that fund our research at Dartmouth. There are federal agencies, contracts with private companies, and gifts from largely family foundations. Okay, so what I'm going to try to do this morning is, first of all, define evidence-based practices. Then I'll spend most of the time giving you an update on the 5 evidence-based practices that we studied in the early 90s in an attempt to implement an evidence-based approach to psychiatric rehabilitation that paralleled the movement in the UK that Graham Thornycroft talked about yesterday. And then I'll talk some about common themes in effective practices and in the way that they're evolving in psychiatric rehabilitation. And finally, I'd like to say a few words about the bigger problem of dissemination and implementation. Okay, so in the US, the mental health system has really been, for many, many years, a cottage industry that was dominated by sort of individual approaches to almost every mental health condition. So, and that remains true to a large extent today. You know, when I take my family member with severe depression in for treatment, the kind of treatment that they get depends almost entirely on the door that we happen to walk through. You know, they might get family treatment, they might get psychoanalysis, they might get cognitive behavioral therapy, they might get medications, they might get hospitalized. If they're in California, they might get past life therapy. A whole range of things that's available in the US with very little oversight by government or other organizations. And in this chaotic system, there's been very little attention to outcomes or effectiveness. That is, what actually works, or trying to figure out what would work for specific people depending on their characteristics. And there's been the tragic outcome that many ineffective and harmful practices, such as psychosurgery, such as sheltered workshops, that are actually harmful to people have grown up and been used for many, many years. And the counterpart of that is that it's been a very slow process for us to try to implement effective interventions. Now, all of this has been changing for the last 20 years as part of the influence of evidence-based medicine. And just to remind you all as background, evidence-based medicine is built on the three pillars of using the best science, trying to make sure that clients' preferences are part of all decision making, and trying to make sure that the clinicians delivering the care are really experts and skillful. In mental health, this combination of three elements really means doing our best to integrate science and recovery ideology. Even though they're sometimes not totally complementary, and I think my colleague Mike Slade will explain some of these difficulties in much more detail. Okay, so what are evidence-based practices? Well, very simply, they're interventions that work. And interventions that we've been able to test not just in university settings and small controlled trials, but in real-world settings. Interventions that work in terms of the best science, which is hopefully randomized controlled trials. Interventions that look at objective measurable outcomes and outcomes that are meaningful and valued by the people who are participating in the services themselves. That's a high standard, but that's what we aspire to in the evidence-based practices movement. Now, in 1998, again, very parallel to the changes that Dr. Thornycroft talked about, there was a large conference in the United States sponsored by the Robert Wood Johnson Foundation, which is our largest healthcare private foundation that funds grants. And the thrust of the conference was, look, we know a lot about what works in mental health care, but we also know that these interventions are rarely available. And so let's focus on the population of people with serious mental illness, those who are, the 2% maybe of people who are disabled for many years by mental health problems. And let's see if we can demonstrate that we can implement these services in a variety of routine mental health settings across the United States. And this conference selected 5 interventions that, for which they thought the evidence was so robust at that time that they should be part of routine care in every community mental health center in the United States. The 5 interventions, so these are not my choices, these are the interventions that were handed to us by this National Conference of Mental Health Services researchers. So the 5 interventions were assertive community treatment, supported employment, family psychoeducation, illness management and recovery, and integrated treatment for co-occurring disorders. And what I like to do next is to review these interventions, some of the evidence for them briefly, but talk about what's the current status of these interventions now, some 10 years or so after we've made a big effort to implement them on a national scale. Okay, so I'll start with assertive community treatment because it's really was the first intervention in the U.S. that was researched in community settings and developed robust evidence base that it could be helpful to people who had severe and persistent mental illnesses. You probably are all familiar with the ACT model. It involves a team that takes longitudinal responsibility for a finite defined group of people with the most serious problems and tries to reach out to them in the community, help them through crises, be available to them 7 days a week, 24 hours a day, help them learn skills for coping in the community. And in 1980, this was the most prominent community-based rehabilitation intervention that we had. And as I mentioned, I worked with 3 of these teams in Boston for a number of years. The research on ACT has been pretty clear and robust. This is a review that Kim Musser and I did back in 1998, and the findings here are pretty typical of studies up to that time. It showed that for people who had been long-term in the hospital, or who were homeless, or who were having difficulty engaging in services, ACT was very effective at helping them to stay out of the hospital, helping them to become stably housed in the community. And then the one other outcome that seemed to be consistent across studies was that clients were highly satisfied with this service compared to services as usual. They enjoyed knowing a team and knowing them longitudinally and being able to access care in the community. You'll notice too, which I think was we were interested in back then, that ACT did not necessarily have positive effects on other outcomes of interest. And so one of the things we started working on back then was how to do a better job of helping people to find jobs, and helping people with social connections, and helping people to avoid jail and prison and that sort of thing. Okay, here's a typical ACT study. This was done by Tony Lehman in Baltimore, and it just shows that over time, people who are homeless and mentally ill are much more likely to develop stable housing and stay out of homeless settings. But much has changed since 1998. Hospital systems in the U.S. have changed completely. In the 1940s, if you were hospitalized in Connecticut for a severe mental illness, the average length of stay for an initial hospitalization was 40 years. Today, the average length of stay in Connecticut is about 2 weeks, I think. And in New Hampshire, it's very rare for us to have anybody in the hospital more than a week. And so that sort of undermined the basic cost-effectiveness argument about keeping people out of the hospital, because there are no hospital beds anymore. For a population of 1.5 million in New Hampshire, we have 100 beds, and that's it. And it's been that way for years. The deinstitutionalization occurred in the 1970s in New Hampshire, and by the 1980s we had gone from 4,000 or 5,000 beds to 100 beds. And so the game has all been out in the community rather than getting people out of hospitals, although there are still a few places in the U.S. where hospital closure remains an issue, as Dr. Hogan described yesterday. Another change that's occurred in the U.S. is that in our high-quality systems of care, and you have to understand that there are 50 U.S. states, so we really have 50 systems or maybe non-systems of care, but they're very different from one another. And so usual services in the better states, like Ohio and like Connecticut and like New Hampshire, usual services have to a large extent incorporated many of the principles of ACT. So all of our care in New Hampshire is delivered by teams. All of our care is delivered out in the community. All of our care is multidisciplinary. You don't need to be on an ACT team to get those kinds of services. Another thing that's changed in terribly adverse fashion in the U.S. is that rather than being in hospitals in many states, people with severe mental illness are vulnerable to be in jails and prisons. And that is particularly true in some states like Texas, and it's particularly true for people who are from minority backgrounds like African Americans and Latino Americans. And so there have been many attempts to modify ACT so that it addresses some of these issues and becomes culturally competent working with these other groups and focuses more on the problem of helping people to stay out of jail and prison rather than hospitals. And that's been, you know, by and large, not very successful. The studies of forensic ACT teams have not showed that they're effective in helping people to stay out of jails and prisons. In fact, many of the teams have a corrections officer on the team, and the teams just serve to increase surveillance and many times result in people going back to jails and prisons more rapidly because they're violating some minor condition of their probation or parole. And there are other attempts to expand ACT that have been even more disastrous. I think many states have tried to assumed that well, ACT is the most effective and intensive service we have, so let's apply it to people with personality disorders and people who are sex offenders and people with all sorts of other behavioral problems. And so far as I can tell, none of those attempts has been particularly positive. And another problem in some states has been that the ACT teams themselves have refused to transition people to less intensive services even when they're very, very stable. So I visited many ACT teams where you know, the great majority of people on their caseload are you know, doing just well, but the ACT team you know, holds on to the idea that was initially expressed in the 1970s when we knew little about long-term course in the community, that this should be a lifetime intervention. And there are other places in the U.S. where they've long since abandoned that outdated philosophy, and when people are stable, they transition them to other teams. So in New Hampshire, for example, all the care is team-based, but very, very, very few people get the ACT intensity. Most people are on teams that have 30 clients per case manager, and the people who are particularly stable, the caseloads can be even higher than that. And over time, most people don't need team-based services anymore. You know, the people that I've been a doctor for 25 years now, for most of them, I'm the only person who ever sees them in the mental health center. You know, I see them once a year. They're doing just fine, and it absolutely makes no sense to keep them on ACT teams. So I think that we're ambivalent about ACT nowadays. It probably still makes sense and is effective in some large inner city areas where services are fragmented and chaotic and outcomes are potentially disastrous. It probably still makes sense in states like Texas where usual services are horrible to worse. It probably doesn't make sense in states that have good mental health services. And the last two ACT studies that we did, one in Connecticut and one in New Hampshire, showed that the ACT didn't make a difference compared to usual services. And my guess is that it will fade from existence in many states in the U.S. Okay, so next is supported employment, and I put this second because there's the largest evidence, besides ACT, we have the largest evidence base on supported employment of any of these interventions. I hope all of you are familiar with the supported employment model. It focuses on competitive employment because that's what most people with mental illness are interested in. It involves a rapid job search and de-emphasizing pre-vocational assessments and training and skills building and all of that, because there are many, many, many studies now to show that all of the pre-employment training interventions do not help people to get jobs over the long run. Supported employment, by the way, really came out of developmental disabilities, where long ago in the early 80s, Paul Wayman and his colleagues discovered that if you took the traditional train and place model and turned it on its head and tried to place people in real jobs as fast as possible and then provide them with whatever training and support they needed in the job setting, you really got much, much better outcomes than if you trained them for any amount of time in sheltered settings. And when we began to study various vocational models in the US, supported employment was not the top choice or the most prominent model by any means. Many others were considered by the experts to be the state of the art at that time. But this is one of those areas where when you actually get data, it turns out conventional wisdom is wrong. And almost everything that was in the literature at that time was wrong. I can remember reading that it would take, on average, 6 months of vocational counseling with a client to help them to identify a realistic job choice. But when we actually started interviewing clients, it turned out over 90% of them had a realistic job choice the first day they came in for services. Conventional wisdom at the time was that it was really important to separate vocational services from mental health services so that the vocational services didn't become contaminated by the pessimism and the treatment orientation of clinical people. And that argument, I think, is a good argument. You know, it makes sense that if vocational people can really be much more optimistic and really focus on goals, you know, they should be able to, that might work better than having services in the mental health setting. The problem is that in the field, and when you actually start collecting data, it's totally wrong. There are now a dozen studies that have looked at integrated services versus you know, separate or parallel services, and the integrated services, you know, always do better. And if you really are on the front line and seeing what happens, you know, the reason for that is obvious, you know, right away. When people want to go to work, which most clients do, it's a disaster if the psychiatrist or the clinical team is not, you know, on the same page as the vocational team and is telling the client that, no, you're not ready for work. If it's making you anxious, why don't you quit your job, et cetera, et cetera. I mean, what you want to have happen instead. And I, you know, sort of lived through this transition. I can remember for many years telling people that it was probably better for them to just concentrate on being stable and, you know, go to the day center and that sort of thing. And I'm embarrassed about that now. That was what we were trained to do in the 70s and 80s. But then as supported employment developed, what I learned was that as a doctor, it was extraordinarily important that the vocational specialist came in with the client and would say to me, you know, well, Joe's doing great, but you know, he's really anxious about starting a job, and so why don't we do an anti-anxiety medicine for a week just to get him through this first week? Or Joe is doing fine on the job, but he's really having trouble waking up in the morning, and could we change his medication schedule? Or Joe can't keep up with his job because the medicines are really making it difficult for him to concentrate and stay awake at work. Or Joe can't really do the computer right and hit the small buttons because he's got this tremor from the medications. Well, those were all things that I was missing. And to have the vocational specialist and Joe come in at the same time and help me see these things made it easy to modify the medication so that Joe could work and be successful. So a team-based approach and makes sense and is just much more effective. All of this proceeds completely on the basis of the client's preferences for what kind of job they want to do, when they want to start to work, how many hours they want to work, etc. And once we've helped people to get into jobs, the role of the vocational team is to provide whatever supports they need to be able to be successful. Or if they don't like their job, to quit in an appropriate fashion and move on to another job. The evidence base for this is robust now. I think there are some 20 randomized controlled trials around the world. It's such a simple intervention that it's really hard to mess this up. I mean, there has been an occasional team that doesn't leave their offices and does such a poor job that they can't help people get jobs. But in most cases, people with a college education can learn to do this across lots of studies of supported employment. About 2/3 of the people get into competitive employment within the first year. We're just finishing a huge study in 23 cities, 2,200 people for the Social Security Administration in the U.S. of people who've been unemployed for many, many, many years. And the outcomes of that study, which haven't been released yet, are going to look, just like all the rest of these studies, and hopefully will influence changes in Social Security regulations and policies that we've all been pushing for. This is a typical study. I live up in New Hampshire where there are more moose than people, and when we do studies, they are always criticized by the federal government, and they say, well, that might work in New Hampshire, but you guys are really kind of a Tahitian island up there. You have only white people, and you don't have HIV, and you don't have high crime rates, and you don't have all these good American things, cocaine and such. And so once we find that something's effective in New Hampshire, the first thing we try to do is to replicate it in an inner city area. And this was a study that we did in inner city Washington, D.C. If you visited Washington, D.C., I'm sure you haven't been to Southeast D.C., which is the area where people who are very poor live, where the police don't go because it's so dangerous, where 15-year-old kids driving big fancy cars sell drugs on the streets. And so we went to the homeless shelters in Washington, D.C., and we recruited people who raised their hands, they were all had mental illness. They all had crack cocaine abuse. They were all homeless. But half of them wanted to work, and we took them into a study. And we found that those who got supported employment, many of them got jobs. We've followed these people for years now. Having a job helped them get out of the homeless setting, helped them to stop their crack cocaine use. Many of these folks are still stable 10 years later. And you can see the bottom line, the blue here. What we did for a control group in Washington was that we paid for whatever services people wanted. They could have their choice of any of the many, many, many vocational providers in Washington. They could go to clubhouses, they could go to training programs, and there were many providers in D.C. And the clients went to, had their choice, and some of them tried several different providers. There was no history of any of these providers finding a competitive job for a client. The few people who worked essentially dropped out of services and found their own job, because all these programs really were set up to sustain the sheltered work settings that they were developing. They needed people who are good workers to stay in the setting so that they could keep, putting candy in baskets for distribution or something like that. Okay, now there are many current issues in supported employment. The most important one is financing, and there are a number of federal committees now in the U.S. trying to figure out what's an efficient way of financing supported employment that would work, and should it be financed through the healthcare system, or should it be financed through the disability system, or should it be financed through the Department of Labor, or should it be financed, and it goes on and on. But that's the key issue confronting us now. Another key issue, and this is an example of one of the things I want to talk about, which is that in psychiatric rehabilitation, since it's a new field, the evidence base is changing very, very rapidly. And one of the things we found is that the third of people who are not successful in supported employment tend to have more severe cognitive problems. And there are a whole range of ways of dealing with those cognitive problems. Most of them involve, you know, sort of prostheses or compensatory techniques. They're the kind of things that you and I use every day, you know, that we have a calendar on our desk, we have an appointment book, we have a cell phone that beeps and tells us, you know, when to do the next thing. We have a secretary that keeps our schedule, and on and on and on. Well, people with mental illness need those kinds of compensatory strategies too, you know, and particularly if they have difficulty with concentration or they have difficulty with attention. You know, we found that there are a whole range of techniques, like giving them a beeper that reminds them every few minutes to, you know, move on to the next work element or something like that. There are also many attempts to teach people through computerized games, really, to overcome or to get better at some of the cognitive areas where they're not so good. So, you know, and the research shows that you can increase people's attention, or you can increase their short-term memory by practicing these games 3 days a week. So far, we don't know if if those kinds of strategies add anything to the other strategies, like helping people to find a job where their cognitive problems don't really interfere, or helping them with compensatory strategies on the job. Another issue that's really become prominent is that across all of these studies, it's interesting that there are always effective employment specialists and ineffective employment specialists. So even though, you know, on average across the studies, 63% of people get jobs, I know that in every study there's at least 1 or 2 employment specialists who get jobs for 100% of their people. And they're usually an employment specialist that gets a job for no one who's assigned to them. And so there are a lot of studies trying to just, and you know, this is the sort of good qualitative and anthropological research where you spend time following people who are really effective and trying to understand what they do. And this is a great area of research, I think. You know, for example, now the biggest barrier that we find in helping people get employment is that many clients in the U.S., about 30 or 40%, have a criminal justice record. And when they apply for a job, the employer does a background search and finds that they have a criminal justice record and may not hire them because of that. And so, you know, the clever employment specialists in the field have developed all sorts of strategies for dealing with this. And, you know, I followed some of the employment specialists who are really good at this, and, you know, just to see the things they do. And it's really remarkable how they go in and interview an employer and get to know them and get to know that person's needs. And in the course of an interview or two, before they present any clients at all, they find out, A, if the employer does background checks, and B, what kinds of people they would still be willing to hire, you know, if they do have a criminal justice background, so they know who they can help get a job in that setting. And then there's also the issue of disability reform, and that may not apply in Israel at all, but in the United States, as I talked some about yesterday, all of our disability policies have the inadvertent effect of socializing people into disability rather than encouraging them to be hopeful and to think that they can actually function in life. Okay, so now let me move on to, and by the way, supported employment is just, despite an almost complete lack of funding in the U.S., continues to spread like wildfire because it's what clients want. And now, by contrast, let me talk a bit about family psychoeducation. As you probably know, there were several randomized controlled trials in the 80s and 90s that showed this very structured approach to teaching families about mental illness and teaching them coping skills and teaching them ways of managing or relating to their relatives with mental illness were effective. And you know, these strategies helped the relatives to feel better and to cope better, but they also helped their family members to stay out of the hospital or to avoid relapses. And there were a whole number of studies of this that showed that, you know, you can do this in single families or with multiple families or with the client present or without the client present. It's almost any way people did this, it seemed to be effective. The problem, though, as it's evolved over time, is that outside of university-based research settings, families don't want this intervention. It's very hard to get them signed up. It's very hard to get the mental health center people to sustain this intervention. You know, clients are, you know, no more interested in this than their family members. You know, families want something completely different. Yes, they want education. Yes, they want support. Yes, they want to have a contact with their treatment providers, but they want it not in such a structured, long-term fashion. You know, they want it in intervals and during crises and such. And so there are a whole number of approaches that are in process now that would involve alternative ways of working with families and try to meet their expressed needs in the real world. So I think this is a good example of an intervention that works in efficacy settings and fails in effectiveness settings. And we're now in the process of developing new interventions, but I think we don't really know what to do to be most helpful to families right now. The most popular intervention in the U.S. is a family-to-family intervention where NAMI members learn to provide education and provide it to other families. Okay. Now, a new intervention, which is, again, very popular and really taking off in the U.S. since the 90s, is what we call illness management training or illness management and recovery or wellness management. And when this Robert Wood Johnson project in 1998 identified that you know, people needed a structured way of learning how to take care of their own illnesses, and there were the conference said, and there are a number of interventions out there. Somebody needs to put them all together so that it makes sense as a coherent package. And so well, I got my colleague Kim Muser, who's just a master at putting together a wide range of findings in literature to develop this intervention. And Kim really successfully, I think, combined in a very structured way, you know, psychoeducation, behavioral tailoring, early warning sign recognition, relapse prevention strategies, and cognitive behavioral interventions for residual treatments, and combined it in a way that's relatively easy to use. And the early research on this has really been very nice. And I know there have been at least one good study done in Israel here. David Rowe and colleagues participated in this. But there are a number of studies around the world that are in process of being published. They all show positive results. One of the things I hear again and again when I visit these areas is that it really helps clinicians to grasp what recovery is all about, and it helps clients to be more hopeful and more independent in terms of taking care of their own illnesses. So here, just as an example, is a very early study. Wasn't called wellness management, but if you actually read what they did, Jerry Hogarty and his colleagues at Pittsburgh provided an intervention which they called personal therapy. And they showed the interesting finding that if you really teach people how to take care of their own illnesses, they don't just get better, but they continue to get better after the intervention stops. And that is a great contrast with most everything else we do in mental health. You know, by and large, when people stop taking medications, they're highly vulnerable to relapse. When people stop participating in most psychotherapies, the effects erode over time. Supported employment and illness management are the only two interventions that I know of where you've really given people skills and you've put them in settings where they can function better, and over time the results seem to get better and better after the intervention stops. There are lots of issues with illness management and recovery because it's a new, such a new intervention. You know, we definitely need more research, figuring out how to train clinicians efficiently to provide this intervention, and I know you folks have worked hard on that here. There's really the issue of translating, you know, soft outcomes a bit to harder outcomes, and trying to simplify the intervention so that it's easier to use. Okay, the final intervention that I'll talk about briefly is just trying to help people recover and take care of manage their substance abuse at the same time as their mental illness. In the U.S., I don't know what this is like here, but in the U.S., at least half of the people with serious mental illness have co-occurring substance use disorder, and they general robust finding is that any bad outcomes that can happen to you with mental illness are much worse if you also have substance abuse. And they're much worse by a factor of 2 to 10. So if you have schizophrenia and you drink alcohol regularly, you're twice as likely to get rehospitalized. If you have schizophrenia and you use illicit drugs, you're 10 times as likely to commit a violent act and end up entangled in the criminal justice system. So over the last 20 years, there have been a whole series of studies to try to develop interventions to help people with their recovery from substance abuse as well as mental health. And these interventions are, you know, assertive. They help people in a very individualized way because some people want to pursue mental health before substance abuse, and some housing before substance abuse, and so on. And so it's a very client-centered intervention that really helps people in a fashion that they choose. But there are now over 50 controlled studies of integrated interventions of one kind or another. In general, the results are very positive. You know, this is an early study that Greg McHugo did in New Hampshire, showing much higher rates of people in remission from their substance abuse when the substance abuse counseling was provided by the team rather than referring people to substance abuse programs. We're now trying to standardize the intervention. Now that we have, the most interesting thing here, I think, is that now that we have lots of studies, it turns out that most teams are doing the things that are not very effective, like providing substance abuse counseling and motivational interviewing, and they're not doing the things that are most effective, like providing peer group support, providing residential programs that help people with their recovery, and providing people with supported employment that gives them an alternative to the lifestyle of using substances with their friends. And so we're trying to, you know, sort of change the model of IDDT and the training to help make sure that teams don't just do the counseling, but focus on these most effective elements. Okay, so let me wrap up with just a few slides. One of the most interesting parts of being in this field for a while now, to me, is that interventions in psychiatric rehabilitation that actually work, those that are effective, share lots of common features. First of all, they're based on shared decision making, so they really proceed from what the client is interested in. And they pay attention at every step to the client's preferences, to offering the client choices, to making sure that the client owns, the intervention. Second, these interventions that are effective are highly individualized. They're not cookie-cutter interventions. They really depend totally on what the client's needs and interests are. So, in a dual diagnosis program, if a person has a terrible trauma history, it's ineffective to try to get them to stop drinking, because every time they stop drinking, they feel horrible. They have nightmares, they have flashbacks and all. You really need to deal with the trauma first, before or at the same time, so that you can help them with their substance abuse recovery. Now, the issue is going to be completely different for a client who has essentially, destroyed part of their brain by years of drinking and has very little, volitional capacity and observing ego, and is going to need lots of environmental supports for being sober. And those clients don't need psychotherapy, and they don't need trauma interventions. They need to be in a structured setting that helps them with external supports, and on and on and on. All these interventions focus both on skills and supports that people need to reach their goals in the community. They all focus on the kinds of adult roles and quality of life that people identify as their goals, rather than stabilization and symptom control and relapse prevention, the kinds of things that we as professionals have tended to focus on. There are lots of rehabilitation practices, by the way, that I haven't talked about, that have research-based, social skills training, supported housing, trauma interventions, and on and on. I've just tried to give you an update on the 5 interventions that we studied intensively for many years. I've made some comments about how some of these interventions were successfully disseminated and implemented, and others had great difficulty. Just to make a few overview comments about that process, and I'd be glad to send you lots of data on implementation strategies. But there's no simple solution for implementing a complex intervention in a chaotic real-world situation. It takes, the more strategies you can use, the better. It's got to be tailored and individualized for a particular setting. It's got to involve all of the stakeholders. We've got to really pay attention to fidelity over time. It's not like teaching docs to use a new medicine. It's very complicated to teach a whole team to do something correctly. In the National Evidence-Based Practices Project, we found by and large that with training and supports for a year, most teams were able to implement the interventions that they chose successfully. It was more difficult for complex interventions like IDDT and IMR. It was easy for simple interventions like supported employment. This is just to illustrate that the strategy I think one wants to use is to involve all of the stakeholders in working together to identify strategies and barriers. One of the main learnings from this project, though, was that even though we developed extensive materials for consumers and family members to participate in implementation, they essentially all got screened out at the clinic level. We found almost no clients who had ever seen the materials. And so we're now working on developing electronic decision support systems that be available widely on the web and in peer centers and in clinic waiting rooms and everywhere else, so that all of the material goes directly to clients and their family members. It can't be screened out. I think I'm not going to try to go through all of these lists of implementation strategies, because I know I'm just about out of time, but I would be happy to send you articles and materials and videos and training materials on any of these evidence-based practices that you're interested in. And let me just say in conclusion that I think you folks have done a wonderful, wonderful job in moving ahead so rapidly in psychiatric rehabilitation. In many ways, you're ahead of the rest of the world. Nobody else has really made the commitment to make access a right, and nobody else has defined a package of services so carefully, and nobody else has put this in legislation, and nobody else has committed 25% of the mental health budget to this. I think you're doing all of the right things. It also sounds to me like you're very focused on including consumers and family members in this process and paying attention to their wishes and helping them to be part of the teams. I hope you will also pay attention to the evidence base and use data to guide what you're doing and to improve the course of your services over time. And this is an evidence base that changes very rapidly. I don't think that we want to get into the trap again of teaching everybody an intervention and then finding out 5 years later it's out of date. I think you would like to train clinicians and train consumers to be thinking that these interventions need to be flexible because they're changing and we're learning more all the time. I can promise you that 5 years from now, psychiatric rehabilitation will have a completely different evidence base, and we will be much more effective at helping people, to find relationships and to find jobs and to, find other adult roles in the community that they truly value. I work in a research center. Part of our job is to disseminate things. If we can send you videos, books, research articles, please contact Patty O'Brien, and we'd be happy to do this. If you want to download any of the toolkits from the Evidence-Based Practices Project, they're all available at this SAMHSA website, and you can download the videotapes illustrating the practices as well as the fidelity measures and the guidelines and the manuals. Thank you very much.